Hello and welcome to this presentation on advanced pharmacology of the eyes and ears. I decided to make a separate PowerPoint regarding eyes and ears because this is something you're going to see a lot in practice, and I thought that going into it with a little more detail was important. All right, otitis media, one of the most common things you're going to see in children. It's an infection of the middle ear. It can also cause rupture of the tympanic membrane. Now, acute otitis media occurs in children more frequently than adults, but it can occur in adults. I I see several cases. I had 2 cases this past week of adults with acute otitis media. So it's not super common, but it can occur. It happens more frequently in children because of their eustachian tube. Their eustachian tube is more lateral and shorter, thus making it more difficult for the fluid of the middle ear to drain down out into the maxillary sinus. So when a child gets a cold or has allergies, the tube narrows and makes it even less likely for fluid to drain. That fluid backs up in the middle ear, thus creating a wonderful medium for bacteria to grow and develop and proliferate and cause this ear infection. The most common bacteria that you'll see associated with ear infections is strep pneumo, H flu, and MCAT. So remember, when we are going to provide our prescriptions, we want to ensure that we are using antibiotics that will cover those 3 types of bacteria. Anytime we are prescribing antibiotics, there is no one treats all. Doesn't work that way. Each antibiotic has a different mechanism of action, and each bacteria respond differently. So we have to have a good understanding of the bacteria and the antibiotic to ensure that it's going to be effective. Patients with otitis media often have had a history of acute upper respiratory infection. Sometimes they do, sometimes they don't. Most of the time they do. I had a patient last week who had a bad cold, and she ended up going on a flight. The flight caused intense ear pain, but she was okay. She got to her destination. Return trip, ear pain, terrible, terrible, terrible. She ended up feeling blood come out of her ear, and she had indeed caused a rupture of her eardrum due to the pressurization in the aircraft. But not to worry. The eardrum will heal itself, but she needed to be treated with antibiotics for her ear infection. So adults can get it. Less common, but adults can get ear infections. Okay, I like to learn visually, so I teach visually. So we have 4 tympanic membranes. The first one here in the upper left-hand corner, it's pretty good looking. It has some fluid in there. You can see this little gray fluid in there. So that is an effusion. So this is what we would classify as an effusion of the middle ear. That means the fluid is not draining appropriately, but there is no infection. It's nice and shiny still. The bony prominences are visible and where they should be. Now, when we look over here at B, this is a bad one. This is the little child that comes in screaming, holding their ear because they are in so much pain. We have a bulging tympanic membrane, and this one is with risk of rupture. So we're going to treat this little one. Down here in the lower left, this one doesn't look so great either. It's red. There's a lot of fluid in there. I would say that this is a serous otitis media with effusion. So there's an effusion in there as well. Some providers may use a watch and wait with this. Watch and wait, you will see, is I wouldn't say that it's recommended, but it is something that providers have the option to do. During these days of antibiotic resistance, we only want to use antibiotics when we know that we must do them. Otherwise, we are going to have untoward effects. So if the provider sees this and the patient doesn't look septic or doesn't have that look about them that you get to know, they don't look sick, they don't have that sick look to them, they may watch and wait. And when I say watch and wait, that means tomorrow we're going to either follow up by visit or phone call to identify the how the patient is doing. But it wouldn't be outside the boundaries to prescribe antibiotics for this patient. That's why the American Academy of Pediatrics has listed them as guidelines and recommendations, so that if you choose not to watchful wait, you are not violating any standard of care. You have that leeway to treat. Now you'll see in the bottom right hand side, this is a little one who has a tube in the ear. Sometimes when children get recurrent ear infections, the provider makes the decision to have a surgeon place a tube in the middle ear that will help to drain the fluid from the middle ear, hence reducing the incidence of ear infections in the middle ear. So this is a child that has 4, 5, 6 ear infections in a year. We worry about potential damage and hearing loss, so this may happen sometimes. Now these ear tubes will typically fall out on their own. As the child grows, the eustachian tube becomes more, it begins to lose that lateral aspect to it, so it drains better, and the child will naturally have fewer ear infections, thus no longer needing the ear tube. It will fall out, the hole will close on its own. I've only seen one ear tube in my career that had to be surgically removed because it just was in there so good it wasn't coming out. But it can be kind of shocking when you see that for the first time as a student or as a new provider. Okay. Otitis media treatment. The treatment depends on the age of the patient. So if a child is over 6 months of age or an adult, you may choose watchful waiting. Again, you will find most evidence-based clinical guidelines states that watchful waiting with otitis media is an option. But they use words very carefully whenever they create these standards and guidelines. They often use words like recommend, so that if you choose to treat the patient, that you are not going outside of the standard of care. So when selecting watchful waiting, we must consider the pain. Warm compresses to that side of the head, Tylenol or Motrin. If antibiotics are used, the standard of care first-line antibiotic is high dose amoxicillin. If they have been on antibiotics for any reason in the past 30 days and it was amoxicillin, then we aren't going to use it. So let's say we have a child. She comes in. She was treated 3 weeks ago for strep with amoxicillin. We're going to use something else. Now, if we choose to use amoxicillin on this patient, they're a good candidate for it. They're not allergic. They haven't been on antibiotics. We're going to treat 90 milligrams per kilogram with a day. So you have to figure that out, 90 milligrams per kilogram per day. And that is the amount of milligrams they need a day. Now, if you have a really obese patient, and we have a high level of obesity in the pediatric population today, it may recommend doses that are way out there. So we need to be very careful that we do not ever go over 875 milligrams every 12 hours. That's the cutoff. We do not want to exceed that in the pediatric population. We can go higher in adults if we need to, but with the pediatric population, no, we're not going to do that. For patients with penicillin allergies, the first-line treatment is Cefdinir. Cefdinir is a cephalosporin. Now, if the patient has had an anaphylactic reaction to penicillins, I would be cautious about using a cephalosporin because there is a 20% risk of them having another allergic reaction. They are not the same drug, but they are like cousins. They have similar molecular bodies. So I would keep a close eye on the patient if I was giving them Cefdinir. Second line antibiotic is amoxicillin clavulanate, or that's Augmentin, or clindamycin with or without ceftriaxone for patients with penicillin allergies. You can use Zithromax. I'm throwing that out there. That is something that you can use also. Otitis externa is an infection in the outer ear canal. You may know it being called swimmer's ear. Well, you don't have to swim in order to get otitis externa, but it increases your risk. Bacteria gets in there, and it's dark, warm, moist, all the things bacteria likes. But it is an acute infection in the outer ear canal. It can also include the inner ear, the pinna, the outer ear, or both. And it can be caused by bacteria. I've also seen some cases of fungal otitis externa, and I have a picture I'm going to show you. Risk factors, exposure to water, and using earplugs, hearing aids, skin conditions like eczema or psoriasis greatly increase the risk. The treatment depends on the age and whether the tympanic membrane is intact. Pain management and removal of exudate is very important. Now, I would have to say the majority of the patients who have otitis externa, it is crazy painful. In fact, sometimes the ear canal is swollen so tightly shut that I have to insert a little wick in there because the drops won't penetrate. So we want to try to remove any exudate that's in the canal, but always be conscious of the pain element. It can be very painful. So if the patient is in intense pain, I'm not going to be aggressive with removing that exudate, although it will help in the healing process. So here's a picture of an otitis externa. You can see there's discharge on the outer ear. Sometimes this part of the ear is swollen also. And when you take the otoscope and you look in the ear, this is what you're going to see. The ear canal is narrow. I have seen some ear canals, and when I'm doing my documentation, I always document the percentage of narrowing of the ear canal. So this looks like it's maybe 20 or 30% narrowed, but I have had ear canals that are totally occluded. So make sure that you document that and document the characteristics of any exudate that is in the ear. This is an example of otitis externa with that is a fungus. The exudate is often white and has little black dots on it. That's pretty characteristic. I once had a patient, this was a few years ago, she had been coming in, seeing a different provider for otitis externa, and she came in over and over again, treated with antibiotic drops with no improvement in her symptoms. And I took one look at it and I said, that's because this is fungal in nature. We need to use something totally different. It's an acetic acid that we use in fungal infections. Antibiotics aren't going to help it at all because we're not treating a bacteria, we're treating a fungus. So the treatment is eardrop. Oral antibiotics are not effective in otitis externa because the antibiotic cannot reach the concentrations needed to penetrate the tissues of the outer ear. So we use an eardrop. And we also need to identify whether the eardrum is ruptured. There are some drugs that we do not want to use at all if the eardrum is ruptured because patients can have an otitis media and an otitis externa at the same time. I just had 2 patients last week with the same thing. So it's treated with ear drops. If we are unsure whether or not the TM is intact, and that may be because it's so narrow, but we can't see it, I'm going to choose ofloxacin, ciprofloxacin, or ciprofloxacin with dexamethasone. This one can be used in combination with hydrocortisone. They're called, they have brand names for them too, but get into the habit of using the generic names, because on your certification exam, that's what you're going to be held to. So I think one of the things that's one of the tips that I give students, because I think that I became more familiar with the brand names, and then that was a learning curve, and I had to start studying the generic names after when I was graduating, when I was studying for my exams. So just get familiar with them right from the beginning. But ofloxacin is a fluoroquinolone. It is safe to use if there is a question that there may be a rupture in the tympanic membrane. And again, if there's significant swelling, the provider may need to put a wick in there. The patient will then place the drops on the wick, and the wick will bring the medication into the inner ear. I've had great success with it. So let's move on. Eye conditions. A lot of disorders affect the eye. We're only going to discuss a few. We're not going to talk about penetrating injuries. We're going to talk about conjunctivitis and infections in the eyelid. We are not going to talk about corneal abrasions or glaucoma, because you'll learn about those things, those treatments, when you move on into your adult health. So right now we're going to focus on conditions of the eyelid and conjunctivitis. Now, this is a fancy word for an infected eyelid or stye. Chalazion or hordeolium. They are the medical terminology for a stye. So it's an acute infection of an oil gland on the eyelid. You can have them visible, where you can see it externally, or internally, where you have to flip the eyelid up to look and see. And a chalazion is a sterile inflammatory granulomatosis response from an obstructed gland. So it is almost like a little sebaceous cyst in there. Staph is the most common bacteria, and I advise all my patients to use hot compresses several times a day. I will use antibiotic treatment on these, but typically they will often go away on their own. Lid scrubbing, you want to use like a baby shampoo that won't hurt your eyes when you're scrubbing your lids. Make sure you take your makeup off before bed. And these conditions are important because you need to rule out some big deals, which we're not going to talk about today, because you're going to learn about these in depth later on in your coursework. Preseptal and orbital cellulitis. These are conditions that are you cannot miss diagnosis. So, but you'll learn more about that as you get into your clinical classes. And this is what they look like. So you can see this one here. It's often found above the eyelashes of the upper lid. It's firm and it's painless. The stye, it is most often found near an eyelash follicle, and it hurts and there's swelling. These will often spontaneously drain. And these often have to be removed. So they do a little D-I-N-D there. So a little incision and drainage to pull that out. These will most often than not go away on their own with warm compresses, but I will also give them an erythromycin antibiotic eye ointment to use. It just makes it go away a little bit faster. So topical antibiotics are usually not effective because of the depth of the infection. You can use orals if you want to on an internal. So that's the ones that you can't see on the outer eye. You have to flip over the lid and then you can see it. You want to use an oral antibiotic for that. With the external one, you can use the ointments. I always use my fallback erythromycin 4 times a day, and I haven't had any difficulty with it. Chalazion, I know I'm not saying that correctly, but topical or oral antibiotics don't really have effect on this because you have that little, it's almost like, as I said previously, a sebaceous cyst in there that needs to be removed. Although sometimes they'll use a steroid injection to use it, to remove it. Conjunctivitis, I see this a lot in clinic. It can be caused by viruses, bacteria, or allergic components. Viral conjunctivitis is the most frequent form of conjunctivitis. And we'll go into the other commonalities between the three so that you can help to differentiate if it's bacterial, viral, or allergic. We are not going to discuss chlamydial conjunctivitis. You'll learn more about that later on in the coursework. All right, so here are some examples of conjunctivitis. Bacterial conjunctivitis, now this yellow stuff, they used a stain on it to make it more prevalent for the photo, but this is yellow pus. Bacterial conjunctivitis usually is limited to one eye. The conjunctiva is pink. When they wake up in the morning, their eyelids crusted shut together. The exudate is always purulent, and they otherwise are well. They don't have any runny nose, cough, nothing like that. They feel good. Viral conjunctivitis. The patient usually has symptoms of a viral infection as well, with runny nose, congestion, cough. The exudate that comes out is more of a thick, clear, or white substance. It can be limited to one eye or can affect both eyes. Allergic conjunctivitis. The biggest characteristic, I think, with allergic conjunctivitis is that it's usually in both eyes, and their eyes are very teary. There isn't any crusting, and their eyes itch. They've got that itchy that you don't see as much. It's not the most predominant symptom in bacterial or viral, although it may be present. And then we have chronic dry eye, and we have a subconjunctival hemorrhage. It looks worse than it actually is, but we're not going to discuss that in our presentation today. The treatment for conjunctivitis or pink eye, I have them listed here. What are you going to use most often? Okay, I have to say most often I use this combination. This is the generic name. It is a sulfa drug with polymyxin added to it, 1 drop 4 times a day. It's probably the most common used. If the patient is allergic to sulfa drugs, you cannot use it. Secondly, I would probably say ciprofloxacin, 1 drop 4 times a day, works really, really well. If you have a really bad case where it is resistant to treatment, I'm going to go up to the tobramycin or the gentamicin. And something you need to consider as well with eardrops and eye drops as well is cost. Some of these drops are incredibly expensive, and if the patient does not have insurance or if the medication is not covered by their insurance, they may have a $200 prescription waiting for them. So you do need to become cognizant of the cost of medications because we want to ensure that we are providing care to our patients that is affordable. Allergic conjunctivitis, we spoke a little bit about that, but we're going to use antihistamines, mast cell stabilizers, and my favorite thing of all time, Pataday. Pataday is and there's another one out too. I can't remember the name of it offhand, but it used to be a prescription eye drop. It is an antihistamine for the eyes. It burns like crazy when you put it in. It's one drop, 24 hours, and it really, really helps people who have allergic conjunctivitis. All right, the treatments. Now, again, we want to consider cost as well. Many of these medications are now over the counter. So, Astelin. This is an eye drop that used to be prescription only, one drop 2 to 4 times daily. This other one, too, Emidastine, 1 to 2 drops, one drop 2 to 4 times a day. Mast cell stabilizers, NSAIDs, of course, and antihistamine and mast cell stabilizers. These are also over the counter. So it can be quite tricky to identify the causative agent in conjunctivitis. You need to first identify whether you believe it to be viral, bacterial, or allergic. So I hope that these slides helped you in gave you some greater information on conditions of the ears and eyes.